Pooja madam, unmute yourself.
Good evening, everyone, all Nebaoi members. So today we have come to another class of Nebaoi Classroom. This topic is basic rhinology, and our expert is Professor Surinder Singhal, and speaker is Devashruti Chakrabarti, and moderators are Manish Singh and Manu CV from NEGRIMS. So now I request Dr. Shubhamoy Chakrabarti to introduce our expert, Dr. Professor Surinder Singhal.
Thank you, madam. Good evening to all. So welcome to the Nebaoi Classroom. So our today's external expert is Professor Surender Kumar Singhal. He is MS DLO DNB Fellow of European Board of Otolaryngology and Head and Neck Surgery, MNAMS, FIMSA, FICS, FSCS. Currently, he is the Professor, Department of ENT, Government Medical College and Hospital, Chandigarh. He did his MBBS in 1986, DLO from Government Medical College, Rohtak in 1990. He did his MS from PGI Chandigarh in 1994, DNB in 1995, and he did his European Board of Otolaryngology and Head and Neck Surgery in 2017. Other specialization trainings, he received that endoscopic sinus and skull-base surgery from Penn University, Philadelphia, USA, and endoscopic sinus and skull-base surgery from University of Adelaide, South Australia. Areas of specific interest, microear surgery, including cochlear implant, endoscopic sinus and skull-base surgery, and head and neck oncology. So previously he was associated with Associate Professor GMCH Chandigarh, then Assistant Professor same GMCH Chandigarh, and he was also in BP Koirala Institute of Health Sciences, Nepal since 1997 to 2006. Teaching experience, he is having more than 28 years of teaching experience. He has the Fellow of American College of Surgeons, Fellow of European Board of Otolaryngology, Head and Neck Surgery. He is the Fellow of International College of Surgeons, Indian Section, Fellow of International Medical Science Academy, member of National Academy of Medical Sciences, and he is the member and the life member of various societies of associations in India, particularly pertaining to otolaryngology. He has received multiple awards, including Dr. I.S. Gupta Best Paper Award for Senior Consultant. Then he has got more than 102 publications in index, out of which national 52 and international 50. So I welcome you, sir. It is a great honor to Nebaoi that you have given your consent to become the external expert in this our classroom. I welcome you, sir. Madam, please.
Thank you, our President, Dr. Shubhamoy Chakrabarti. May I request our Honorary Secretary, Dr. Anjan Bhuiya, to introduce our speaker, Dr. Devashruti Chakrabarti.
Good evening, everyone. In our Tuesday's Nebaoi Classroom, our speaker is Dr. Devashruti Chakrabarti. So she is a very dynamic student during her time, and now also she is doing excellent work. She is working in Silchar Medical College Hospital for last 2 years. She did her MBBS from Silchar Medical College, Assam, and did her MS ENT in Guwahati Medical College. She worked as a medical officer in Sribhumi Civil Hospital for 5 years. So maybe she has got a general exposure too. It is a great exposure. So she has got approximately 7 years of clinical experience and presently working as a registrar in the Department of ENT, Silchar Medical College. With that, I welcome Dr. Devashruti to deliver her lecture. Maybe today's lecture will be a very interesting one because it's on basics of rhinology. So maybe it is a very vast topic, and everyone will learn from your topic, and we'll have a good source of discussion after that topic. So I welcome Devashruti for his deliberation.
Thank you, Dr. Anjan. Now, to introduce the moderators, actually our Chairman Scientific Committee, Dr. Hirendra Bora, ma'am. Ma'am, are you there? Hirna, I think she is network is problem. So I will introduce the moderators, Dr. Manish Singh. Dr. Manish Kumar Singh, MBBS from AMCH and TLO from JMCH, and done his fellowship in endoscopic sinus surgery and skull-base surgery under Dr. T.N. Janakiram Trichy, presently working as consultant ENT surgeon at Brahmaputra Hospital, Dibrugarh. And our another moderator is Dr. Manu C.V., is assistant professor ENT Negrims. He has done his MBBS, MS from JIPMER Pondicherry. Then he did his DNB and MNMS, and he joined Negrims in 2019, worked as a senior resident till 2022. Then he worked in Sri Lakshmi Narayan Institute of Medical Sciences, Pondicherry, as assistant professor from 22 to 23. And in 23, he joined Negrims as assistant professor. Till date, he's working as assistant professor. He has 40 publications till date, and national and regional conference attendance. A lot of conferences he has attended. 5 in national conferences he has presented paper. And his area of interest is mastoid surgery, cochlear implant, endoscopic sinus surgery, thyroid, parotid surgery, lateral skull base surgery, and allergy. I welcome Dr. Manish and Dr. Manu CV. Thank you.
Thank you, ma'am, for this, for having me here.
So now, may I request Dr. Debashruti, please start your presentation.
To all the yes, ma'am. Good evening to all the good evening to all the dignitaries present here, and thank you for inviting me as a speaker here. This is a very prestigious platform. So now I'll share my screen. Is it visible?
Yes, yes. Do it full screen.
So today's topic is basic rhinology. We all know that basic rhinology is a very vast topic so it will be very difficult to cover everything in details within 30 minutes, but I'll try to give emphasis on the topics which are clinically very important for us. And hello, is it audible?
Yeah, you can continue.
So before starting the basic rhinology, as we all are clinicians and we are interested more in the clinical cases, so I have put up a case scenario. This is a 38-year female came to our OPD with a history of left-sided nasal obstruction from last 6 months, decreased smell sensation from associated with it, and on and off nasal discharge, unilateral headache, and visible mass in the nose. So we did the local examination where we find that a pale glistening polypoidal mass is seen in the left nasal cavity. Then we did the probe test where we could pass the probe 360 degree and it is insensitive to touch, did not bleed on touch. Then we did the posterior rhinoscopy here. You can see that the clinical pictures has been given. So we did the posterior rhinoscopy also where we could see a polypoidal mass is seen hanging from the left side of the choana. Even from the oral cavity examination also, I am citing it with the arrow. A mass is seen hanging from the choana to into the pharynx. Then to confirm our diagnosis, we did one DNA, and in that DNA we could see a polyp in the middle meatal region on the left side, and it is obstructing the osteometal complex. Further confirm your diagnosis, we did a CT PNS, and where we could see a mass in the haziness in the left maxillary sinus, and it is occupying the left nasal passage. Along with it, it is occupying the choana also. So our provisional diagnosis, final diagnosis was it's an enterochoanal polyp, and the patient has already taken many conservative therapies before. So we decided to operate the patient. We did a functional endoscopic sinus surgery and we removed the polyp. So with this case scenario, I'm starting my basic rhinology topic. I have divided the rhinology topic into 4 parts like applied anatomy of nose and paranasal sinuses, physiology of the nose and paranasal sinuses along with mucociliary clearance, nasal cycle and airflow dynamics, and basics of the diagnostic nasal endoscopy. The very first slide that I have chosen is the external nasal framework, because Nose is the structure which is the most prominent structure in our face, and it is more prone for the trauma and facial-maxillary injuries. So we should know the framework of the nose. So what are the parts? Bony and cartilaginous parts are there. So the bony part is constituted by the nasal process of the frontal bone, the nasal bone, then the frontal process of the maxilla, and the cartilaginous part is made by the upper lateral, lower lateral, and the minor alar cartilages. What are the clinical importance of this structure? One is your nasal fracture, and the others are the cosmetic deformities. Moving on to the next slide, we will now talk about the nasal septum. This is very important because it divides the nasal passage into two cavities and it supports the nasal framework also. When we see the nasal septum, we can divide it into four parts. First one is the columellar septum. Then it is formed by the middle cross of the columella. Then the membranous septum. Then comes the septal cartilaginous septum formed by the septal cartilage. The bony part septum is formed from main contribution from the perpendicular plate of ethmoid and vomer. Minor contributions are from the rostrum of sphenoid, the nasal spine of the frontal bone, crest of the frontal bone, crest of maxilla, and the crest of palatine bone. What is its clinical significance? It is applied significance is that many patients may present to us with deviated nasal septum, which will lead to obstruction of nose and it may lead to chronic sinusitis. Then patient may present with septal hematoma from trauma, and septal fractures we may see in few patients. Moving on to the next slide, this is the blood supply of the nasal septum, where we can see the main supply are from your internal carotid artery and the external carotid artery. Internal carotid gives ophthalmic branch from which anterior and posterior ethmoidal artery arise, and external carotid gives facial artery from which superior labial, and it gives a septal branch. Another branch that external carotid gives is the maxillary artery, from where greater palatine and the septal branch of sphenopalatine artery arises. Now, what is the importance of this? Because this anterior ethmoidal artery, the septal branch of the superior labial, greater palatine, and the sphenopalatine, this form a plexus at the anterior part of the nasal septum, which is known as that area is known as little area and the plexus is known as Kieselbach plexus, and this is the most common site of anterior epistaxis. This slide is very important. Now we are moving to a very important structure in our nose, that is the lateral nasal wall. This has a very high surgical importance. We have three turbinates: superior turbinate, then middle turbinate, and the inferior turbinate. And beneath the turbinates there are metastases. Then this has very high clinical importance because our sinuses and many other structures drain into it. We will now talk about the meatal drainage. From this diagram, you can see that we will start from the inferior part. In inferior meatus, this is the, in the inferior meatus, this is the opening of the nasolacrimal duct. So anywhere, if there is obstruction anywhere here, so the patient will feel, sometimes there may be blockage in the nasolacrimal duct also. And in the middle meatal area, this area is the key target area of the functional endoscopic sinus surgery. Which are the sinuses where drain into this area? Frontal, anterior ethmoid, and maxillary. In the superior meatus, the posterior ethmoid drain, and there is a sphenoethmoidal recess from where the sphenoid sinus drains. This is another diagram showing the drainage pathways of the sinuses. This slide is very important because in the lateral wall of the nose, the most important structure is the osteomeatal complex. And if we find a block there, it may lead to rhinosinusitis, and it is the key target area of PES. What are the structure present here? These are the uncinate process, ethmoid infundibulum, hiatus semilunaris, bulla ethmoidalis, middle meatus, and maxillary ostium. So moving into the next slide, we will see a CT PNS photograph, and here I can show you the osteomeatal complex very clearly. This is the middle turbinate, and fortunately or unfortunately, it is pneumatized, that is concha bullosa we can see, and this is the uncinate process. This is the bulla. Gap between this is the hiatus semilunaris that will lead to the ethmoid infundibulum and the maxillary ostium. There are some OMC variants which are surgically very important. Now I'll show you in the picture itself. This is a pneumatized middle turbinate known as concha bullosa. Then this is large bulla ethmoidalis that can cause obstruction in the your osteometal complex area. In this picture, the third picture, you can see a paradoxically curved middle terminate. That means middle terminate should curve laterally, but there is a curve medially. Next is the Heller cell. This is pneumatized anteroethmoid cells just infraorbital area, and this is a Agarnese cell just near to the lamina papyracea. This slide shows the variation in the attachment of the uncinate process, which is also very important. So in the first diagram, we can see that the uncinate process is attaching laterally to the lamina papyracea. In this one, the green one shows the attachment, the green part. So in the second diagram, this is attaching to the cribriform plate. In the third one, you can see that it is attaching to the middle turbinate. In the fourth one, it is lying freely in the middle meatus, and in the last one, the uncinate process is pneumatized. Now come to the venous drainage. This is important because from the nose, from the anterior most part of the nose, some infection may travel to the cavernous sinus also. This can happen through the ethmoidal veins to ophthalmic veins and directly to the cavernous sinus. Another important point here is the Woodruff venous plexus is present on the lateral wall near the posterior end of the middle turbinate. Autonomic nerve supply of nose is very important. Later when I'll come into the nasal cycle, we will describe it. Two types of supply, sympathetic and parasympathetic. Sympathetic causes vasoconstriction and decreased nasal secretion. Parasympathetic causes vasodilatation and increased nasal secretion. Now, after finishing the anatomy of the nose, now we will move into the anatomy of the paranasal sinuses. We know that we have 4 sets of paranasal sinuses: maxillary sinus, ethmoid sinus, and the frontal and sphenoid sinus. Maxillary sinus are the most common site of your rhinosinusitis. Why? Because it has an anti-gravity drainage, because the maxillary ostium lies above the sinus, and any dental infection can also travel to that sinus. Next, coming into the ethmoid sinus, if there is a infection in the ethmoid sinus, it is lying close to the lamina papyracea, and the infection can travel to the orbit and lead to orbital cellulitis. Other sinuses which are important, frontal and sphenoid, these are surgically also difficult to enter, and sphenoid sinus lies close to the optic nerve and the internal carotid artery. Intentionally, I have put this sinus for the student, this slide for the students, because this shows the development of PNS. So we have to know that maxillary sinus and ethmoidal sinus, these two sinuses are present, appear first at birth. From birth it is present. But sphenoid sinus and the frontal sinus, they appear later. At sphenoid at 2 years and frontal at 4 years. So if an infant comes to us, we may not find any frontal and sphenoid sinus. So this is not an abnormality. This is just a natural development. Now we have finished the anatomy in very brief due to time shortage. Now I am going to the physiology of nose and paranasal sinuses, along with it airflow dynamics and nasal cycle. We know that the basic function of the nose is respiration and olfaction, main function. But in the process of respiration, there are some minor functions also which are very, very important. These are heat exchange, humidification, filtration, then nasal resistance, then mucociliary clearance, neurovascular nasal reflexes, then voice modification. The other function of PNS are vocal resonance, then reduction of the skull weight, then flotation of the skull in water, and increase in the olfactory area. This slide shows the mechanism of respiration. Here we can clearly see that on the left side, the air which is going inside the nose is in a laminar flow. And here this is not shown. When it goes inside the air, it divides into 2 columns, above and below the middle turbinate, and again rejoins in the guana. But while in expiration, we can see that there is an obstruction at the area of the nasal valve, that is Lyman nasal. So these AD currents are generated, and this ventilates the paranasal sinuses. Now, when we come to the ventilation of sinuses, this is just opposite of the nose. During inspiration, there is negative energy generated in the nasal passage, so all the airs are sucked out from the sinuses. But during expiration, there is positive pressure in the nasal passage, so the sinuses get ventilated. So this is important, nasal resistance. So we know that the nasal valve, they keeps a positive pressure during the expiration so that the alveoli does not collapse during the expiratory phase. After the your airflow and this nasal resistance, we will discuss a little bit just in short about the rhinomanometry, where it's a dynamic test of nasal function that calculates the nasal airway resistance. And there are three types: active anterior rhinometry, passive anterior rhinometry, and active posterior rhinometry. This is the apparatus with which we do the rhinometry, and this is the flow chart. Acoustic rhinometry. In acoustic rhinometry, actually we calculate the narrowest part of the nasal cavity or minimal cross-sectional area, and we, based on the analysis of the sound waves reflected from the nasal cavity. This is the diagram which shows the acoustic rhinometry, the procedure of doing acoustic rhinometry and the graph. So this slide is very important. I'm explaining this for our PGTs and the undergraduate students, if anyone present here. If a patient comes to you with a complaint that doctor, my one nose is blocked for some time and the other nose, then after a few hours it subsides and the other nose get blocked. So please treat me. So will you treat the patient? Obviously, you will evaluate the patient whether there is any obstruction or any other pathology is there. If everything is normal, you will reassure the patient because this is just a normal thing. This is nasal cycle. So how the nasal cycle happens? There is reflex periodic alternation in the nasal airflow resistance between the two nasal cavities. So each cycle lasts for 4 to 12 hours. And due to it is mainly regulated by the autonomic nervous system, the sympathetic and parasympathetic. And due to congestion and decongestion of the venous sinusoids in the inferior turbinates and anterior nasal septum, it occurs. So what are the factors which modify the nasal cycle? Temperature, humidity of the surrounding air, then head positions. I think you have all experienced that with head position, the nasal cycle changes. Then body temperature, physical activity, emotional and psychological status, then your thyroid status, nasal decongestant, and antihypertensive. Now we come to the nasal reflexes. So we all know that when we smell something delicious, our saliva starts saliva increases its secretions, and that occurs because of the smell reflex. It increases the saliva and gastric juice. Second is your nasopulmonary reflex. With chronic severe nasal obstruction, there may be development of the pulmonary hypertension. Third is the sneeze reflex. It's a protective reflex against the foreign body or any nasal irritants. Another function of nose is vocal resonance. We know that nose and paranasal sinuses provide vocal resonance to few consonants like M, N, and G. So ma, na, an. These things are pronounced by the vocal resonance, and if the nose is closed, then that will be B, D, and G respectively. It will be pronounced like that. So air conditioning. Under the air conditioning is a major function of the nose, and under the air conditioning, there is filtration, temperature control, and humidification. The filtration, the particles more than 3 microns are in the inspired air are trapped by the nasal vibrissae. Then temperature control, heat exchange occurs between the venous sinusoids of the turbinates and the inspired air. Humidification, secretions of the nose and paranasal sinuses humidify the inspired air. Now, protection of the lower airway. This is a very major function of nose. If you do tracheostomy to a patient which bypasses the nose, so this function actually decreases. So what is that function? What is mucociliary blanket? That this traps the pathogen in the inspired air and transports them to the nasopharynx. Sneezing, it's another protection reflex. protects against irritants, and lysozymes are secreted, which kills bacteria. Immunoglobulin A and E are present in nasal secretions, and interferons are also present. Now, coming to the mechanism of the mucociliary clearance, this is important because because there is a sol. We know that the respiratory epithelium is the ciliated, pseudostratified ciliated columnar epithelium, and the cilia, there are sol and gel layer. Most of the time, the cilia are in the sol layer, and the gel layer is above that sol layer. Only the tip of the cilia is in the gel phase, and the propulsive phase is very quick, and the recovery phase is slow. So with the every bit, the cilia propagate the mucus blanket just like a conveyor belt. Factors which decrease the mucociliary clearance are mucociliary function of the dry atmosphere, smoking, infection, extremes of temperature, hypoxia, and other drugs. Now, olfaction is a major function, and I cannot go into details of everything due to the time shortage, but olfactory area is the superiormost part in the nose along the at the cribriform plate. The nerve roots are come from the sinus to the nose, and in the superior turbinate area and the adjacent septum, this area is the olfactory area. This is the olfactory pathway. Few classification of the olfactory dysfunction like conductive loss, sensory neural loss, and the central olfactory neural loss. These are the types of anosmia. Here we can see some olfactory function test, and most commonly used is the University of Pennsylvania smell identification test, and we have some values also. Depending upon that, we can diagnose the patient. Now, now I have completed the pathology and physiology of nose in very brief. Now, going to the basics of endoscopy. What are the indications to diagnose the disease of nose and PNS, to diagnose source of bleeding, to assess medical and surgical treatment, and to take sometimes biopsy from nose. Which anesthesia is needed? Topical anesthesia. This is the instrument we use: endoscope 0, 30, and 70 degree, and a suction tip. What are the passes? First, second, and third pass. Third pass is very important. Here I can show you a video. In this video, the lateral side, there is inferior turbinate. Medially, there is nasal septum. We can see a spar, and above there is middle turbinate. In the first pass, we go up to the nasopharynx. So now they will go into the nasopharynx and see the eustachian tube opening, fossa of Rosenmuller. This is the on the lateral side, there is eustachian tube opening is there. Adenoid, if it's a child, will be present medially. This is the middle turbinate. They are going to the sphenoethmoidal research to see the second pass, but probably could not do it. This is the third pass. This is the middle turbinate, where you can see the uncinate process and a bulla behind. And gap between this is hiatus semiluminous. So this in short finishes everything. Now I will just highlight few recent advances in the rhinology, because with the recent researchers, the rhinology has evolved from structural anatomy to a dynamic and neuroimmunological discipline. So few topics, I'll just highlight that topics that the CRS, that is chronic rhinosinusitis classification, has now changed from phenotype to endotype. That is, endotyping is a pathophysiological classification from the, it depends on the T helper cell actually, type 2 and non-type 2. In type 2, there is more chance of polyp formation, and the action of biologics are also very prominent in this type. So in near futures, probably if we can classify, we can avoid some surgeries. In non-type 2, that is, infection is the main pathology, and surgical intervention is very needed in that case. Nose acts as a neuroimmunological organ. We have all seen in the COVID era that nose-brain axis is there, and due to neuroinflammation, there may be anosmia. Others are the nasal microbiome, because if there is a dysbiosis, it may develop chronic rhinosinusitis, allergic rhinitis, and polyps. So we have recently seen that in allergic rhinitis, some probiotics are also given as a therapy. CFD revolution, rhinomanometry explains that one, that airflow is more important than anatomy, and it can be used in planning of the surgery as well as drug delivery. Nasal cytology and AI, we know that AI has entered in every field of medicine. So there may be AI-based cell detection, which we can use the biomarkers like eosinophil and periostin, and that we can we can plan the targeted therapy and prediction. Biologics like dupilumab, I have already told that biologics have a role. Dupilumab and mepolizumab, this decreases polyps, then decreases steroid dependency, and that may shift to medical control in near future. Now, regenerative rhinology, the plasma-rich platelet and the stem cells, these have a role in the olfactory regeneration, and this has a very big relevance during the post-COVID anosmia, in the treatment of post-COVID anosmia. Other points that we all know, like infection and environment, due to environmental pollution, also the rhinological diseases are increasing. Then imaging advances with 3D endoscope and high resolution imaging, we can diagnose the cases better. And the last one is that now rhinology is shifting to some office-based procedure also. These are minimally invasive, we can do under local anesthesia, and these are cost-effective and patient-friendly also. So this almost finishes my presentation, but at the later part, I will try to show some pictures for the students also. These are some radiological and clinical pictures. This is a CT nose PNS. This shows that there is a fracture in the nasal bone. On the right side also, this shows a fracture. Along with it, there is a structural deformity also. This is a plain extralateral view. This one is a plain extralateral view. This shows a fracture in the nasal bone. This is a 3D reconstruction of the facial-maxillary CT, and this shows a nasal bone fracture. This is another slide which shows the lateral view of the nasal bone, and where we can see a typical Chevrolet fracture. We know that two types of fractures are there, Chevrolet fracture and Georgia-Wave fracture. So this is a typical Chevrolet fracture. And this is a CT of PNS showing a deviated nasal septum. This is the deviation here. Moving on to the clinical picture. This is a septal hematoma that has to be drained very quickly, otherwise there may be septal abscess formation and there will be deformity of nose. This is important. This shows this CT, you can see in the CT scan, this is the inferior turbinate hypertrophy, and endoscopic views are there where you can see the inferior turbinate hypertrophy is there, which is a very important cause of nasal obstruction. This is an Waters view of the CT-PNS, which shows the frontal sinus, ethmoid sinus, maxillary sinus, and the nasal septum in the middle. Moving on to the next slide. This is an endoscopic view. This shows a active bleeding. I can show you with the marker. This shows an active bleeding here from the Little's area. And here is the role of endoscopy, where we can diagnose the patient precisely and we can treat the patient at the same time. So we can cauterize, if we can locate the bleeding point, we will cauterize with electrocautery or with a chemical cautery, and we can stop the bleeding. So hospital stay will also be less. So this is another clinical diagram. This shows this is the nasal septum, this is the middle turbinate, and this is the inferior turbinate. We can see some discharge here. It is coming from the middle meatus. This is a sign of chronic rhinosinusitis. That is active discharge coming from this middle meatus. With this, I conclude my today's presentation.
Thank you very much, Dr. Debashruti. It was a very beautiful and detailed presentation. So may I request our expert to give his comments on this presentation, Dr. Surinder Singhal.
Yeah. Thank you, Dr. Debashruti. It's a very nice and comprehensive presentation, starting from anatomy, physiology, and then you included the latest advances also. And you have stressed a lot on osteometal complex.
Excuse me, sir.
Sorry?
Debashruti, can you stop sharing your slide?
Yeah, okay, ma'am. I'm doing it. Yes, ma'am. Stopped it.
Hello?
Yes, sir. Carry on.
Yeah. So you discussed about osteometal complex, which is a target area for FES. But nowadays we see, as you have mentioned in your endotypes also in CRS, So osteometal complex is not the only cause of sinusitis. There are other causes also. So we have to address those things also. One point. Second point regarding nasal cycle. It's a normal physiological cycle. We understand it, but there is a dilemma. When do we say it's normal? When it say it's abnormal? Because patients do come with these complaints. At our place, I tell my residents, okay, when the obstruction is permanent on one side, it's pathological. It's not physiological. When it is changing alternately from one side to the other side, that means it is physiological. Otherwise, it is pathological. So this is important regarding the nasal cycle. And then you mentioned about neuroimmunological organ has a recent advances. Very good. There are so many things which are important from this point of view. There is a nose brain axis, two-way side. Nose itself can give signal to the brain that there is an irritant in the atmosphere. So we start sneezing, we avoid that allergen or that irritant. So it's a very good thing and evolving, and research is going on this, and we will come with something very important in this. Then you mentioned about airflow dynamics. Very good. CFD you mentioned. With this, you can operate on a virtual model of a patient, and you can know which area requires surgery and which area does not require surgery. Because there are patients, when you operate, say for example, you do septoplasty, still patient keeps on complaining of obstruction. So in those virtual stimulation, if you do it, then you can judge where you want to address, which area of the obstruction you want to address. Then it's also important in drug delivery, this CFD, which you mentioned in your presentation. And then there are various things you mentioned like biologicals, but I don't know in India biologicals are available or not, and that are too costly. Whether we can practice it in our routine otolaryngology practice or not, because there are certain side effects also of these. You have to be very careful when you are administering these biologicals. These are some of my points in your presentation. The other thing you stressed upon the important the relations of the ethmoid sinus and lateral related to orbit, then sphenoid sinus related to internal carotid artery and optic nerve. So one has to be very cautious, and one has to do a lot of cadaver dissections before you actually proceed on these areas. Otherwise, one should start with the basic phase first, and later on he should advance to the advanced phase. So I think I conclude my points regarding your presentation. Very nice presentation. I am really impressed. Thank you.
Thank you, Dr. Surinder. May yeah. May I request our moderator, Dr. Manish and Dr. Manu, to take the questions in the box?
Yes.
Dr. Manish.
Very good presentation, Dr. Debashruti, and thank you, Professor Surendra sir, for sharing your valuable inputs. So some of the questions from the audience is that, especially from Fukan sir, how is anosmia possible in the case presentation which was presented in the beginning?
Pardon, sir?
Dr. Manu, your network.
Yeah. Hello.
Oh,
Can you
hello.
hear me, ma'am?
Your voice is not clear.
Yes, Manish, you are audible.
Okay. Dr. Manu, please continue.
Yeah. One of the question from the audience is that how is anosmia possible in the first case which was described, since it was, although it was a unilateral condition?
I have mentioned that reduced smell sensation. It was not a complete anosmia. That may be hyposmia also. So because the polyp was blocking the airflow to the superior turbinate area, and thus it was causing the decrease in smell sensation.
Yeah, and another question is about the postnasal nerve. Can you please add few points about the postnasal nerve?
Is the posterior nasal nerve, right?
Yes, sir.
Posterior? Basically,
it's a parasympathetic nerve supply to the turbinate, which is responsible for these symptoms of rhinorrhea and sneezing. And some of the people, they do posterior nasal neurectomy. to alleviate these symptoms. I think the question was directed to posterior nasal nerve.
Yes, sir. Posterior nasal nerve, sir.
Yeah.
And Dr. Devashruti, can you please also mention about the color coding in endoscopes as asked by one of the audience?
That color coding
In endoscopes.
0 degree for green.
Color of the ring in different
Yes,
nasal endoscopes.
yes.
in 0 degree was the green one. Then I forgot actually.
Okay.
Then you
So
have
70 degree will be yellow and 0 degree will be green.
Yes.
And black is for 90 degrees if I'm not wrong, and red for 30 degrees.
Yeah. There is a 45 degree also, but that color is not specific.
Yeah. Can you hear me, ma'am?
Yeah, Manish, please.
Dr. Fukan has asked what's the importance of posterior nasal valve?
Nasal valve.
Posterior nasal valve. Is Dr. Fukan there?
We already discussed posterior nasal nerve.
Okay, you're talking about posterior nasal valve.
From
Okay.
pterygopalatine ganglion of the The S or cylinders get nicely describe the posterior nephrectomy done along with the subclavicular other after sex.
Yes, sir. Yes, sir.
We have already explained.
Yes, sir. There was another question regarding the role of interleukin in polyposis. Hello?
Hello, Devashruti.
Yes. Hello.
Can you hear? Dr. Manish is asking something.
Yes. So interleukins are in nasal polyposis that is tight. It again based on the endotyping of the nasal your disease CRS. Mainly in the type 2, there will be a role of interleukins, but not in non-type 2.
Okay.
She is right. Interleukin 4, 5, and 13 are associated with type 2. She is right.
4 and 13 for polyposis and eosinophil.
Yeah,
Right.
4, 5, and 13. Yes.
Yeah.
Yes, sir. Okay, very, very precise and elaborative also in the presentation. It's very informative in such a short time. You've given such a nice presentation. Thank you, Dr. Debashruti. And if there are any other questions, Dr. Manu?
Another question is how to deal with empty nose syndrome.
Yeah, empty nose syndrome. Actually, the network is a bit errant here.
Can you hear, Dr. Devashruti?
Yes, in empty nose syndrome, ma'am, the nose is wide open, but the patient will feel that there is some obstruction. It can occur after any injury to the turbinates and all. And key mechanism is your humidification. If there is less humidification, then normal nasal airflow dynamics, if there is any change. So, but how to deal with it, I don't know, ma'am. Not to take such.
It's a difficult situation to deal empty nose syndrome. And most of the time when you do extensive radical surgery like total turbinate removal, and in those cases you basically get this empty nose syndrome. And you said treatment is a little difficult because you cannot make it less roomy, because it is because of the less humidification, because humidification is not there, filtration is not there, temperature regulation is not there. All those functions are lost because of the turbinate is gone. So it's difficult situation.
And so there are a few more questions on the biologics. One is about omalizumab in allergic rhinitis and the biologics for eosinophilic rhinosinusitis. If you could please add on to that your knowledge.
I think I already mentioned these biologicals are getting into the practice of otolaryngologists these days, but these are very costly. They are not available everywhere. and there are certain side effects also. I have not personally used it because I am in a government hospital and the patient coming to my government hospital are not that rich.
Yes.
So I
Yes.
don't have that much experience regarding omalizumab, these drugs.
Okay, fine.
So I
Okay,
am
fine.
just using simple corticosteroids, nasal sprays, and sometimes low dose macrolides for other variety of sinusitis.
Yes, I totally agree with you, sir. Even we get patients and then they check online and then they ask us about these monoclonal antibodies.
Yeah, Google teacher is nowadays at the top.
Yes, ma'am.
Everybody will come after Google search.
Yes.
Yeah.
And so one more question is that whether X-ray PNS is still helpful in clinical practice or CT is required in all cases of suspected rhinosinusitis.
CT is a better option. But we also know that then in CT is also the rhinosinusitis is overdiagnosed because mild mucosal thickening also it becomes prominent. But CT is a better choice.
Yes.
I think X-ray PNS should not be used these days. It's long back it was used to be and only 30% relevance. And to decrease the cost, you can ask for a screening CT, coronal view, which can give you a fair idea about the disease. And don't do it right in the beginning when the patient presents with symptom. Give a medical treatment, then do a CT scan. So that will not give you a false sense of disease. So a screening CT can be done, which will be better than the X-ray PNS because X-ray PNS has just 30% relevance.
I think Surinder sir does have a point here. Yeah. Hello.
Yes.
Yes, sir. Yeah, totally agree with you.
Yeah.
And any other questions there, Dr. Manu? Because I'm having a problem with the network here.
Okay. I guess only one last question. Uncinate process in sinus surgery. I think this is the last question.
Sometimes uncinate process in sinus surgery. So sometimes we know another process called mini FES where we just incise the uncinate process and nothing else. We don't do anything else. So this has very high importance in sinus surgery, uncinate process. In routine FES, so we always cut the uncinate process and when we do the enterostomy.
Yes.
Actually, Nature has given uncinate process with some purpose because it prevents direct entry of air to the maxillary sinus. And if you do a larger enterostomy, there are patients who complain of neuralgia because of the direct stimulation of infraorbital nerve when the air enters the maxillary sinus. It may be a cold air in the windy atmosphere. So you have to know the size of your enterostomy and the disease for which you are giving it. If it is a fungal pathology, you have to make a larger enterostomy because it's a disease that requires that larger enterostomy. Otherwise, for a simple purulent sinusitis, you can make just a small opening which can drain the sinus and get away. You don't have to do larger enterostomy.
So average we can keep as around 1 to 2 centimeter in routinely speaking.
Yeah. One thing Debasruti mentioned about endoscopy, only local anesthesia. I think we cannot go rigid because in sometime in children you can't do it under local anesthesia. You will require general anesthesia. And sometimes under local you are not able to insinuate under the turbinates. Sometimes patient comes with bleeding. You do a routine endoscopy under local, you don't find anything, and patient still keeps on bleeding. So you just go under the inferior terminal. You might find a small hemangioma over there, which may be bleeding, which is difficult to be insinuated when under local anesthesia. So sometimes you have to choose general anesthesia also for nasal endoscopy.
Anybody has any question? Dr. Shubhamoy? Are you there? Dr. Smriti?
Yes, madam. Very nice discussion.
Yeah.
And thank you all of you, especially Professor Surinder Kumar Singhal and our moderator, Dr. Manish, Dr. Manu, right? Devasuti, you have covered almost all the things, right? So thank you very much, all of you, right, for your precise time that you have spent with this Nebaoi Classroom. And hopefully we'll be continuing that one as our schedule as long schedule are there, right? Thank you very much, all of you.
Thank you. Thank you,
So
Dr.
it was a
Sumay,
very
for
nice
inviting.
discussion.
Thank you, sir.
So
Thank you very much.
Good evening,
last part,
everyone.
vote of
Good
thanks.
evening,
Yeah,
everyone.
yeah,
Fauziya ma'am, I heard you utter my name. So it was interesting and it was good to listen to my resident Dr. Debashruti.
yes. It was very nice presentation. Very nice. Under your
It was
guidance.
nice to go through the discussions also with experts, sir, and the moderators out there. So I'm happy with her presentation. That's all I have to say.
So thank you very much. It was a very nice, beautiful presentation. So the last part is our vote of thanks. So on behalf of Nebaoi, I extend our heartfelt gratitude to everyone who made today's classroom on basic rhinology a great success. We sincerely thank Professor Surinder Singhal for his valuable expert insights. Our special appreciation to Devasruti Chakravarti for an excellent and well-structured presentation covering applied anatomy, nasal physiology, mucociliary clearance, airflow dynamic, and basics of diagnostic nasal endoscopy. We are grateful to our moderators, Dr. Manish Singh and Dr. Manu Siri, for steering the session so effectively and enriching the discussion. Our thanks also goes to Dr. Shubhamay Chakraborty, Dr. Anjan Bhuya for their introduction and coordination. And my special thanks to Dr. Anjana Sharma for doing this favor, because Dr. Rohan, our regular webmaster, is not there. So finally, we thank all participants for their active involvement and the organizing team for the smooth execution of this program. Thank you very much.